pleasure of introducing my colleague as a co-panelist, because Ryan and I will be paneling this discussion together. But Ryan Ashe, at the very far end of the table, is most recent addition to value-based payment OHIP side. Ryan's been with KPMG before that, and KPMG is one of our largest contractors that helps state on movement towards the value-based payment. Ryan's been integral in moving OHIP towards the value-based payment for past 3 years. Just on Monday, Ryan joined OHIP as a director of Medicaid payments reform. So Ryan can tell you a few things about himself, and then we'll move on to the rest of the panelists and start the panel.
Thanks, Anesa. I'm going to try not to take too much time so we can dive in, but as Anesa mentioned, I've been part of VBP effort since its inception, since we started the VBP roadmap. From there, we developed the clinical advisory groups to dive into the clinical aspect. Behavioral health has been part and parcel to that. We supported the pilots, we've done the boot camps, everything really devoted and intended to support the most important piece of this, which is the stakeholders, the providers, the payers, the CBOs, and most importantly, the people that are being served, the Medicaid population. So for me, by virtue of the position I just took, I'm totally committed to the goals of VBP, to achieving ultimately everything that Jacob talked about earlier: quality, efficiency, improved quality, better efficiency, but really changing the way we provide care at the point of care, and really answering the question, what matters to the Medicaid population. One of my priorities as I get underway is to engage all the stakeholders. So some of you I've recognized through the last few years of transition to VBP. I want to continue that engagement with all of you, providers, with payers. I want to understand fundamentally what's happening in your organizations, be it your specific organization or just your network. Those types of innovations, the way you partner with CBOs, the way you implement social determinants of health interventions, you address the root causes of care, of poor health. Those things are important because those are lessons that have to be shared with other providers and payers so that they can achieve not only the goals of VBP, but ultimately the fundamental principles of what it is we're working towards. So I'm committed to that. The state is committed to it. The department is, and there's just three points as we think about contracting. I mentioned one: engage each other early and often because it takes time. Build trust with each other because your success is very much dependent on the success of your partners. And finally, what matters to the Medicaid population? That's really what matters at the point of care. You can turn the needle, improve quality, improve efficiency, and ultimately that's the incentive. That's where your shared savings is. So I'm excited for this. Contracting is a huge, critical piece. And I appreciate AHI and the PPSs that are involved for bringing everyone together. This is the sort of forum that is going to keep the momentum going, but also make sure we understand the principles and learn from each other about how to progress successfully. So thank you.
Okay, so I'll introduce the panelists quickly and then give them some time to actually answer a couple of the questions that we came up with to start the conversation, and then we'll want to engage all of you in asking some additional questions. So right next to me, it's Toni Vazquez from Greater Buffalo ACL. And Toni, I have a couple questions for you. We'll start maybe with that, and then we'll introduce everybody and maybe ask them these basic questions. So the question is, I don't think this is working. You guys hear me if I just scream? Good. How long has your organization been involved in value-based payment? It's like a beginner's question.
Okay. I don't know if I need this, maybe. My name is Toni Vazquez, as was previously mentioned. I'm part of the ACO and the value-based organization in Buffalo, New York. My husband and I, Dr. Raul Vazquez, as many of you may know, collaborated with YourCare insurance company back in 2017, so quite recently, we started the value-based program. We partnered with YourCare, and we manage in collaboration with ECMC, which is the Erie County Medical Center, with Kaleida Health System, which is also a health system in Buffalo, New York, with Jericho Road Ministries Medical Center, which is a healthcare system in Western New York, and of course our IPA doctors of G Health Enterprises. We collaborated with them to obtain 10,000 attributable lives. So that program has been in fruition for about a year now. We've been working with YourCare. We are part of the Total Care General Population, the TCGP contract with that pilot program.
Okay, so our next panelist is Dr. Cupid Gaskin from MVP Healthcare. And Dr. Gascon will ask you pretty much the same questions. How long have you been involved with value-based payments? What your role has been in value-based payments? And maybe, talking a little bit about contracting levels that MVP has moved on yet. And what is the size of population that you're currently engaged in?
Can I answer the question before that?
Of course.
Okay. Yes, it's Cupid. And I have MasterCard and Visa to prove it. So we've been doing, first is, thank you so much. I represent MVP Healthcare, and our vision is to create healthier communities. And that vision without action is hope. And the roadmap for Medicaid payment reform is the action path to help us effect that vision for our communities. And so the question was, how far back have you been in the VBP program? We actually were involved in programs even before the roadmap was paved. And but most of them were in commercial and Medicare. There was one, we had an initiative here, collaborative, with a local health system in the 2014-2015 time period. In the West, we also still have an arrangement which started back in 2014, and it was primarily a shared savings arrangement, and that has been a resoundingly successful program where the shared savings was in the tune of millions of dollars. And with the better health outcomes. So it's not just the cost reduction, but together with that cost reduction, we did see improvement in our health outcomes. So for example, if I may just elaborate a little bit, MVP is part of one of the few areas for CPC Plus. And when we did the analysis, you can imagine with CPC Plus, they have been immersed in an approach to transform primary care. And when we did the analysis on quality, it wasn't a surprise that compared to non-CPC Plus and the CPC Plus, there was a clear advantage. And when we compared the VBP arrangement compared to CPC Plus, there was even a more pronounced quality improvement outcomes. So it works. And so now we are now way into the Medicaid payment reform roadmap path. And we have in the works, either executed or in the process of getting approval, about 7 to 8 VBP programs, most of which are in a glide path. First year, as Anesa said, first year is a shared savings, second year is a shared risk, but we do have some that start off as shared risk. And I think one of the points was, how big, what's the magnitude of the programs? So predominantly, there are some with 10,000 Medicaid lives, some, hovering in the, 2,000. For the combined Medicaid, Medicare commercial program, It's in the larger numbers because of the 3 lines of business. My role at MVP is I'm the Vice President for Clinical Transformation, and I help facilitate the pivot from fee for volume to fee for value at MVP Healthcare. Thank you.
And our last but not least panelist is Mr. Todd Moore from Adirondacks ACO. Can you
All right, thank you.
respond to the same?
No, I'm glad to, and I think I sort of got to orient you to who in the heck I am and how I got here. But I'm very happy to be here. Thank you so much for inviting me. And I'm sorry, I have to say, Ron, you have the most clear and descriptive title of anybody I've met from the New York State hierarchy. And Anesa, it's always fun to see somebody who's got a job that might be more complicated than mine. So. The reason I say that is I actually wear 3 hats, and in a real way. I'm most recently the CEO of the Adirondacks ACO, which is a large regional ACO across many counties in the PPS region that we're in right now, and was founded about 4 years ago to get into the early Medicare upside-only shared savings programs, but now has become the contracting entity for the medical home program in this part of the state that has gone through a demonstration program, a multi-payer demonstration program, rather than the standard advanced primary care New York State model. The Adirondacks ACO is now the contracting entity to preserve those medical home payments from 6 commercial payers and 1 large Medicaid managed care payer, and also to help facilitate the distribution of the remaining Medicaid managed care medical home payments. Now, what happened was, to get the commercial payers to continue on with that, they were interested in, are you willing to move into a more advanced value-based purchasing world? And the answer was yes, if it made sense. And so what we agreed to do as a network of primary care attributing providers and hospitals who also employ primary care, is we took half of the medical home payment, which was traditionally the $7 per member per month, and scaled that at $3.50, which we agreed to take in the form of total cost of care, upside and downside risk. So that roughly is 3/4 of a percentage point of up and down risk. So very low, what we call in our world a corridor of risk. Made it easy to say yes if that was what it took to preserve the $7 that had been put obviously to good use in panel managers and doctors and rent and nurses and things like that. That's what we did. And it was really, once it became apparent that we were going to move into any level of total cost of care risk as a network for our attributed population in 2018, the year we're in now, that we needed to get more serious around having the real infrastructure to do well in that, because we do expect to move up the value chain and take more levels of risk and deliver more value. So I was a long-term board member and helped design the Adirondacks ACO, because my second role is I'm CEO of the OneCare Vermont ACO, which is a statewide ACO in Vermont, now operating under a major all-payer federal waiver that brought a specialized version of the Medicare Next Generation risk-based program, an agreement with the state of Vermont to have a aligned ACO model for Medicaid in Vermont, and an agreement to bring along commercial payers and help encourage them and encourage OneCare to contract with them. So we had planned for 5 years and played in an upside world for 5 years to build the capabilities, confidence, and try to get this federal waiver in order to take one big step over a 2-year period into the risk world. So as we sit now, we're at risk in OneCare Vermont for 120,000 Vermonters, for about $600 million in spend, and a maximum up and downside risk of about $25 million on that $600 million. And we've been planning for it for years, and the all-payer aligned model was really helpful to get providers to go along, because they could start to really envision a big enough book of their book of business across payers being in common models with common incentives. And really the investment in the infrastructure to do it well at that scale through the ACO is something that we set course for years. It just made all the sense in the world to make our partners at Adirondack ACO have access to some of those capabilities through some shared services, through my leadership and some of my team in conjunction with Karen Ashline, who's the Vice President and effectively Chief Operating Officer of the ACO, and Wouter Rietzem, our CMO. And so that we put that model in October 1st. And so I'm still getting up to speed on where we are in New York and understanding the value-based roadmap, but certainly makes sense to me. And, I think really the question to have is, how do we get more providers open to envisioning success and feeling confident to move up that chain? So I promised to have a third title, which is I still am a Senior Vice President of Accountable Care for the University of Vermont Health Network, which, as you probably know, is a two-state, $2 billion integrated delivery system, now with a major footprint in Clinton, Essex, and Franklin counties of New York, and is one of the partners and corporate members of the Adirondack ACO with Hudson Headwaters Health Network, who I'm sure most of you in the region are familiar with, and for others, they're an operator of 17 large-scale community health centers, federally qualified community health centers, and true believers in value-based purchasing and population health management. So I'm proud to say that I work with providers from Brattleboro, Vermont, in the very southern part of Vermont, almost Massachusetts, all the way up into St. Lawrence County, that really believe that we can do better in healthcare. We can be more coordinated, we can deliver higher quality, and that we can embrace payment reform in a way that allows us to work together better. Thank you.
Ron will start us with a couple of questions, and then we would really like the audience to ask questions that you guys have. So we have some, packaged questions that came with our deal here, but please go open the discussion.
Okay, first question for Dr. Gascon from a payer perspective. What factors do you find to be most valuable when considering a contract with a provider? Which elements are most valuable? Is it demographic? Is it data and analytics? Is it overall collaboration between partners? What is the most valuable?
There's really no secret sauce, but push to the wall, it would be relationships and resources. You need a collaborative partner. This is uncharted territory. I mean, though this is demonstration year 3, the fact that Anesa and yourself have been traveling New York State to still preach the gospel of the roadmap tells me, there's still much to be done. We are not yet in the harvesting season. We're still in the planting season. And let's be clear. And there was a question about the CBOs, right? As pointed out, when this was envisioned, it was a big tent, but we're making it even bigger because we do understand that despite our efforts to solve all the problems with the prescription pad, it's not going to work. We need to, extend to the communities, right? And organizations outside, buildings. And so it's about relationships, finding collaborative partners who do see the vision, the long-term vision. At the end of the day, a lot of the responses you will get is absolutely, fee-for-service is intoxicating, right? And we've had that since, 1960s? And now you're asking a fundamental change in both hearts and minds. And that doesn't happen overnight. And so as we plant the seeds of that vision, we need to find collaborative partners. And in our relationships, that's where we ferret out who will, with a pinch of a leap of faith and analyzing the data that we are at the cusp of bankruptcy in our healthcare system, that they're willing to act. If not us, then who? If not now, when? And so relationships are key. The second is resources. And it's challenging, right? Yes, ideally, you'd like to have a partner that has care coordination in place, care management in place, a wow, information system that can do population health management with your eyes closed, right? And brews you coffee. But but the point of having this roadmap is it's not there. We're paving the road of uncharted territory. And so though we wish that the infrastructure is there, it's secondary, right? The purpose of the roadmap is to lift all boats up, right? And bring us to that closer goal of better health for our populations and reducing the cost of our healthcare system. So again, it's about relationships and resources.
Thank you. So if anyone out there has an EHR system or analytics platform that brews coffee, let me know, because that would be great. So any questions before we jump to the next question for Dr. Gascon?
Somebody can go first, that's fine.
Go ahead.
Okay, I was just wondering, would you be able to address the impact of these payment models on the primary care physicians that might be deterred from going into primary care because the system is very administratively top-heavy? I work for Old North Medical Services. We're a private practice in Albany, New York, and trying to attract new doctors into primary care is not very easy in this model, and so the larger corporations are able to attract the very few primary care physicians that come on the market. And I just wonder if any of you have any thoughts about that, because it seems that the only providers that are available to a practice like ours are mid-level providers, and I just wonder where the future is, and if you could address that, or if anybody's thought about that.
So yes, I personally I have. I'm a doctor, and so first is the dirty truth, right? They don't teach this in medical school, right? But and that's number one. Number two, I think you've seen the pivot towards having an awareness of the healthcare workforce, right? Because that's another crisis right there, right? The shortages of healthcare workers, not just physicians, right? And I think if you recall, the federal government even pivoted towards a strong funding for mid-level provider programs, because they recognize the fact that there is a healthcare shortage, particularly for physicians, and it will grow further with the baby boomers getting into that phase of more complex health needs. So I would just like to level set that this roadmap will not solve that, right? But I think the roadmap, if physicians truly understand the goals and the fundamental approach of understanding that even if that patient hasn't visited your office in 2 years, they're your responsibility. Someone who works for my team, I think I'm a bad boss because, and I have two of my team members here, because I asked them to write essays. And so they read essays at our team meetings, and the theme was, why MVP? And one of them, gave a very passionate essay. And she said, the reason why I do this is because I had a close friend who died from colon cancer. And these reports about gaps in care, where you can actually intervene and prevent a death, perhaps we shouldn't sleep so soundly at night if we know that there are gaps in care in our populations. And so, going back to your question, how do we inspire physicians to get into primary care? I think it's through again, with Anesa going throughout the state, explaining and articulating, the vision is that the old paradigm of your accountability being just when they show up at your office, it's not, if we really want to take care of the health of our communities, we need to be proactive. We need to go beyond the office. And I know a lot of it is daunting and intimidating for physicians who were old school, but I see hope. I see hope. There are progressive primary care programs in the country that do liaise and have stronger community relationships and immersions for their physicians. And so it's just, this roadmap is part of it. It's not the silver bullet. But I think if we as a society understand that there is a real problem, we need to use all our resources. As in the roadmap, they speak about the laws needs to be changed. Payment reform needs to be changed, right? Why do we pay more for a preventable admission than a good transition of care? You get paid for a medical error more than giving primary care services. So fundamentally, I think we're still there, right? It's still the planting season, and there's hope.
So one thing that can happen under these advanced population models, and we're doing this in Vermont right now, is there's a movement not just in Vermont but other places to set course for the healthcare system allocation we think there ought to be. And we all agree in 5 years, if it's a better system, there's more money upstream and in primary care. And primary care reimbursement and even the medical home programs are so mature that they sort of stagnated, and we continue to ask primary care to do more. And that creates do the practices have the resources to make it through the day and support the physician and do a team-based model that really can be as proactive as Cupid's talking about, and still attract the individual physician to say, that's a good career path for me personally? And the answer is no, it probably isn't right now. We got to set course for that. So we took, out of that $600 million, we purposefully took $10 million out of the acute care actuarial target and gave it to primary care. And some of that went back to the acute care providers who employed primary care, but a bunch went to FQHCs and independent practices. So we moved the needle from about 5% to between 6 and 7%, depending on how you measure it, of the total cost of care going to primary care. The state of Rhode Island has decided to set course for that being 10% over time from a 5% base, under the same sort of thing as if you do it over time and sort of adjust and pace it with the benefits of better primary care, should reduce demand for acute care, that can work that way. So to me, that's the answer, is we need to get more resources so that the quality of life's there and they can do what we ask them to do. And we got to do it proactively, and I call that the priming the pump money, is what I call it for the hospitals. Is we're never going to succeed if we just try to have the same mentality. We got to at least start to skate for the system that we think it would be if we were really successful.
I'll be part of the primary care panel. Could you attend? Because I have some other things to respond to your question.
So let's shift the gears a little bit towards the ACOs, and I think maybe pose a question of Ms. Vazquez here to tell us if you can share an advice maybe as what that you wish you had when you started embarking on this path of the value-based payment, and maybe talk about specific do's and don'ts that you would like to share with us, or maybe even share a success story or a challenge that you faced or overcome from your perspective while moving towards the VBP or a value-based payment-like contract. Just some good stories or maybe even some bad experiences you had while on this path.
All right, a success story. Because we are in this healthcare delivery system and it's so fragmented, and we tend to live in our own separate silos of healthcare delivery, it's become overwhelming to collaborate and get things under one roof. So what we found in Buffalo was that the healthcare systems that we were partnering with, ECMC and Kaleida and Jericho Road, they each had their own EMR platforms. individual EMR platforms, and they were all different. They were different from each other, and they were different from us. So in order to look at data effectively, it was very difficult, virtually impossible, because these systems didn't talk to each other. So what we did was that we collaborated, and that's how it became a success story, because we collaborated with an entity called Clinigens, and that entity was able to be the integrator, the aggregator project for us in order to link with HealthyLink and to tap into that data from these different EMR systems in order to better use that data efficiently. Some do's and don'ts. I would say the number one do is to continuously, even to a state of nauseam, continuously state your case to the directors of what you need the metrics to be and how you need those metrics to be reported, the process and the outcomes. Because what we found was that once we told the directors to go back to your providers and put these metrics, put these process into place, it didn't always go through. It didn't always, even though we spoke, at different symposiums, we had lunches, we had dinners, we went to their offices, we invited them to our offices, we did all sorts of things to be very creative in order to get them involved in the process. It just didn't transmit effectively down to the providers, and the information was not given to the people that it needed to get to. So the do's is continuously talk to these providers, continuously. The don't would be, don't forget about the do. Don't forget to continuous. I just can't stress enough how changing provider beliefs and behaviors changes outcomes and changes patient behaviors. So our continuous reminders to our providers is I can't stress enough. That's been our greatest obstacle, our greatest challenge, but it's something that it matters. It matters for outcomes.
Data sharing, collaborate.
Yes.
That's what we found on our way too. I mean, the more we talk to people, the more we exchange the ideas, it actually helps, promulgate those things and make sure that they actually come into reality. So collaboration is the key. And our state has been collaborated with some of the providers. We have a great experience with a Greater Buffalo ACO. We were looking for those success stories, and we're looking also to learn from all the mistakes that you made, because you are out there negotiating the contracts, dealing with the providers, dealing with the payers, and the contract, and trying to basically implement what we are telling you, that we think it works because we believe in it, but you guys are doing the work. So we want to hear from all of you what are some do's and don'ts maybe that you have embarked on while either trying to establish the value-based payment contract and arrangements with as a provider maybe, or even as a plan. So does anybody from the audience have anything that you want to offer as a piece of advice to others? Hello, Dr. Vazquez.
Well, tell us about GBOT and the care coordination. Where would you put it in the game? Did it change the game or not change the game?
That's my husband, Dr. Vazquez, so he's setting me up for that. Asking me a question that why don't you tell them, Dr. Vazquez, about GBOT?
Yeah. Do you want a mic, Dr. Vazquez? Yeah. You gotta stand up.
I gotta apologize because I put her in that position. We had somebody else coming in and she played the pitch hitter, so thank you.
She's doing awesome.
I think the biggest don't that we didn't do in the beginning was really to incorporate care coordination early. I think providers are good, but if you don't have the team support outside, it becomes really difficult. And those care coordinators, it's almost concierge medicine. So you've got people that you can pick, especially the ones that have high-risk models, which is the Medicaid market that we deal with, and this total care was an issue. So that was, to us, some of the things that we really implemented. And there was a question about primary care. So our ACO is primary care driven. So we want those practices. You have the attributed lives. Primary care will be the rulers of this road. So I know that people, you know, the insurers and everyone's looking at it a little bit different. But for us, primary care is the only entity, and because our primary care tied into our health home, we became the lowest cost, ER, inpatient, utilization, because it's primary care. That's the secret sauce. So I just want to tell that one primary care physician with the group, you know, we're looking for you because we're coming across the state. And I think we're the only ones that can really change care through an ACO product.
Dr. Vazquez, responding from the health plans, we also believe that the primary care physicians will rule this new tomorrow for healthcare, because clearly you do need that focal point for managing the population. So we are aligned. Furthermore, the roadmap keeps us aligned. It's a primary care. The total cost of general population is fundamentally a primary care physician-driven model for population health management.
So I know we have a couple of minutes left. We just want to maybe open it up to the audience and just pose any questions since we have payer and provider representation up here.
Can I, oh, there you go. After her, can I ask a question?
Of course you can.
To the point of Dr. Ohlendorf's representative, I was just wondering if there is any future of recruitment becoming part of that roadmap, because that, in essence, is going to lead to the quality. You got to have the manpower to be able to care for the individuals we're caring for and be able to recruit people and show an attraction for that recruitment. Right now, the costs, the Medicaid costs haven't gone up for reimbursement in quite some time. So it makes it very difficult to be able to pay your staff.
Workforce development is almost always included by CMS in all of these waivers, and I'm not sure I've seen it done really well. I mean, there's got to be a workforce development element of DSRIP, right, Eric? And you know, the challenge is how do you do it again within adjusting a system that doesn't have a lot of money just to give to increase salaries to those providers? And you know, I think it's a great question. We need to keep an eye on it.
There was a lot of press locally about UVM medical students rotating into the Hudson Headwaters clinics for a year. Could you comment on? I mean,
Wildly successful creating primary care residencies across this region with an eye toward getting them to connect with this region and hopefully stay, and even providing incentives for them to stay. The interest in these few slots that we've gotten to have been massive. I mean, we've gotten great applicants for every position and a very, very high match rate. And you know, it looks like the early returns are people are planning to stay in the region and practice. So I think if we can do more of that with you know, Albany and University of Vermont Health Network, that makes a lot of sense too.
would you say, or could you talk to how you kind of depict for them during that internship this new future as opposed to kind of the traditional fee-for-service? Are they just seeing patients, or are they getting kind of oriented to this new model?
Yeah, we're trying to get more into the new model, of which we've taken some real tangible steps in the arenas that I talked about. But we know the job's not done, and you know, whether these primary care residents choose to be in a hospital-operated practice or join Hudson Headwaters Health Network or go into independent practice, we're trying to tell all of them their best future is through value-based network, working together, you know, with the whole continuum of care, including CBOs at the table. That's going to be the most rewarding work, and really that we really get that the medical home does need to be the quarterback of the system, and that they need to be, you know, supported to do what we're asking them to do, and again, not just completely burn them out as they try to do it. So.
Can I ask my question?
Yes, please.
All right. Could you please raise your hand if you're in a value-based payment level 0 arrangement? So it's just incentives. Keep your hands up, please. Now raise your hand if you're in a value-based payment level 1 arrangement. Keep raising your hand. We'll get to the other levels, right? All right. Please raise your hand if you're in a value-based payment level 2 arrangement. Keep your hands up. And if you are in a value-based payment level 3. So it's still planting season.
I assume Vermont didn't count, but that actually would have been my answer to the question that you asked Toni. Is the upside fee for service incentive doesn't work as a financial incentive. I'm sorry to say it. It just was too weak. It works great as a quality incentive, oddly enough, because in all 3 programs in Vermont and the Adirondacks ACO Medicare program, increased quality scores every year in every program for 5 years. And I think it goes along that you don't improve what you don't measure, and it's easy to get doctors to really engage and their staff to engage in measurable quality improvement. So that helped, but really moving toward and having an eye toward when you move to those level 2 and level 3 risk, I think you got to envision that. Otherwise, it's probably not worth trying to build the infrastructure and the capabilities to do well. And I know it's tough, but it can be done.
I have a question. Can you hear me? Hi. I'm a community-based service provider here in the Capital District. And one of my biggest concerns is exactly what Toni just described, was getting the data and information quality that can make sense. If I go into a risk arrangement with a provider, I need good quality data, timely data and information, so that if I need to make adjustments, if you will, to my business model, I need that timely data. What are the recommendations or the strategies that I could employ in order then to be able to get good, timely information and data out of these systems in order to better meet my targets?
So just unabashedly build a multi-payer claims database with some analytic capabilities on it, and if that means you got to join, if that means you got to join an ACO that's got access to the resources to fund that and capitalize that, then that's what you ought to do, or be in a big enough IPA that you can do that. I mean, the payers are really trying to do their best to provide what they can through portals and things like that, and that can be helpful for a while, but that's no substitute for having real-time available data on the total cost of care and the total experience of your patients. In Vermont, we've successfully hooked up to the state health information exchange to match clinical data to the claims data to really do big data. And once the doctors in Vermont realize that's what we had, it's sort of insatiable needs that they want to see that data and design reports and have some self-serviceability, and that's what we're trying to do.
Sure, I just want to add to that quickly. So there's the payer, right, that you can partner with, and I think folks are doing that. But there's also other providers that perhaps you partner with today, or that based on where you see yourself, your organization going and your business model, thinking about your value proposition as a CBO, what population do you serve, and reaching out to those existing providers. One other resource I would say, and sort of why we're here, is the PPS. So PPSs are doing some pretty innovative, some pretty awesome things, building out data and analytics capabilities. They're using proxy measures. So those proxy measures for those PPSs that are doing that, that provides you some more real-time or more frequently real-time way to measure your performance or measure how you can impact, whether it's the provider or payer that you're partnering with. I know there's some providers out there who look into open source what's available just to the public, whether it's, I think it's 211 in Western New York. If you look at what they have out there, it's basically a dashboard that shows for social determinants of health how the population trends. And so you can identify, my goodness, 90% of the folks have a problem with access to care. If I'm a CBO and I provide transportation to care, I mean, if that were me, I'd say, okay, who's doing level 2 VBP? I know factually that per the roadmap, you have to contract with a CBO. I'll be at your door to say, this is the service I provide. I know that folks have a problem with access to care. I can help you, and I also know that you have to partner with a CBO, so I can make it easy, and here I am. So I think reach out to all those partners, payers, providers, PPS, and then other avenues that you may not really think about. Those are resources, so I hope that's helpful. And then one more question, I think you said, or? Okay, I'll leave it up to you.
Let's thank our panel. I think this was a great